Hello and welcome. My name's Alana Gordon. I'm a reporter at The World covering global health. This is a live Q&A about the coronavirus pandemic and the latest on variants and rapid testing and so much more. Joining me is Michael Mina, Assistant Professor of Epidemiology at Harvard's T.H. Chan School of Public Health, someone we've been checking in with throughout this pandemic. Michael, thank you for your time and for joining us. Lots of questions are coming in.
Well, very happy to be here again. Thanks.
Awesome. And so to you all tuning in, you can post your questions for us on Facebook at Forum HSPH, or you can email them to theforum@hsph.harvard.edu. This Q&A is jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and The World from PRX and GBH. Michael, there's a lot to unpack, but just in the US, multiple variants are now circulating. They appear to spread more easily and quickly, some of them. This is also happening as the country is rolling out vaccines, and we've seen different developments, for example, with the pause in the Johnson & Johnson vaccine. And there's also now, as of this week, the ability in the US at least to purchase rapid tests for testing for coronavirus without a prescription. And so to start, I mean, this has been quite a bit of developments in the last few months and weeks and days even. How did these things play into the pandemic, both as tools and challenges in controlling it moving ahead?
Yeah, nothing like starting with a big question there. So certainly what we're seeing now, we're at I feel like every time we talk, I say we're at a pivotal point in the pandemic, et cetera, et cetera. But here we are finally at this position where we have a very large number of people in this country getting vaccinated. And that is, of course, first and foremost in everyone's minds, I would say. It's become common discussion. Are you vaccinated yet? And most people actually, especially in the older age classes, are able to say yes, at least that they've had one vaccine. So that has, that almost immediately, well, over a number of months now, has led to a sense of relaxation around this pandemic, especially in the most vulnerable age classes. And that's, of course, a necessary thing. We need to start getting the community feel safer. At the same time, we have this battle ongoing between new variants, which are racing forward. And they are, as you say, they're appearing to be more transmissible. And we have pretty good evidence now to suggest that quite a number of them are more transmissible. And so it's put the pressure on getting vaccines out even quicker. And the US has actually done a pretty good job at increasing our efficiencies with getting these vaccines out. Millions of vaccine doses are being given a day now, which is really an astounding and terrific goal that we have achieved, and sort of a pace of vaccination. But of course, we're seeing the new variants are continuing to burst onto the scene and continuing to keep the country on high alert, essentially. And so I think, frankly, this isn't particularly surprising. Variants were always on the table here. We talked about them in the middle of last year. We knew that variants were very likely to arise. We just weren't looking for them before. And so, of course, the moment we actually started any sort of robust sequencing program, which is the way that we look for the variants, we actually have to sequence the virus strains, we started seeing them. And then we actually started seeing, one of the reasons why America has been flat, for example, in terms of the case counts, we were going down pretty quickly in February. And then it started to flatten out. And that's really this interplay between vaccines limiting spread and new variants applying pressure at the community level to increase spread. And so all of this
mobility too, right?
Sorry?
And people's mobility too, right?
Absolutely. That's exactly right. And so people are starting to open up, things are starting to open up. And so all of these, there's a lot of things, essentially what we want to do as a society directly contradicts it essentially contradicts control measures. Like if we want to just freeze the virus, then we don't move at all. Obviously, that's not sustainable. We did that a couple of times already. So we are trying to balance in a very precarious way, balance the need to get society moving again, get back into our lives. It's now, nicer weather in much of this country, for example. And so people are really wanting to be outside, which is good, get outside. But they're wanting to move around more. And so we are seeing an interplay here that is, It is a difficult thing to control, though, as we're seeing, for example, in Michigan, where we've seen cases really become quite a bit higher, right? When other places in the country have really been getting to very low numbers.
And then the other just aspect as we kind of kick off this conversation, and one of the themes of the last time we spoke has to do with the testing. So for example, how does that play into it? I know last time we spoke and following up, the idea of more accessible, quick testing can help people in immediate circumstances, knowing before, for example, going to see a loved one in a long-term care facility or something, know whether you might be infectious in that moment. And at the same time, the tests are complicated, expensive. So what sort of developments on that front have you found? And how does that play into also control in terms of the spread?
Well, for a year now, I've been really pushing for wider access to inexpensive fast tests. And that's been a long slog, but I'm happy that just yesterday, actually, tests like this one. This is actually like one of the first over-the-counter tests to be authorized and actually hit shelves. This is the Binax Now. It's the same test actually that's been used that the government bought in huge numbers last year. And now it's actually starting to show up on CVS and Walgreens and Walmart and such, the shelves of these places. And so we're seeing the testing landscape change pretty dramatically. And this is absolutely crucial, especially as people, the fervor over getting tested has certainly diminished. And so people are increasingly unwilling to just, drive an hour out of their way or sit in a parking lot to get a test. And so it's been crucial that these tests become more and more accessible. I would have liked to have seen really inexpensive $1 tests become available last summer. That could have potentially prevented the major surges or helped to prevent the major surges and hundreds of thousands of deaths this winter. We can't reverse time, but what we can say is now that we are in a position where we are starting to see more people vaccinated, there's going to be, it doesn't mean that we can let go of all control measures. And one of those control measures is to know if you're infectious, especially before you walk into a hospital or a nursing home, for example. You might want to take an inexpensive rapid test, and they are becoming much more available sort of day by day, finally. And so I think that that's been based on some regulation changes at the FDA that essentially created a pathway for at least a small number of these tests to come to market as an over-the-counter test. And it is, I think, Americans in general in the US should probably plan to have greater access to more affordable tests. They're not the public health tests that I've been pushing for in terms of a $1 test that you could take 2 or 3 times a week to really slow community transmission, but this is one more step on the pathway towards that. These are accessible, easy to purchase tests.
So I want to just go back to variants and something that you talked about with that. And we do have some lots of questions coming in that I will pepper throughout this. But when I was bringing up and you were confirming that we're finding that some of these variants are more easily transmissible, like what makes certain ones concerning and makes them more transmissible? And are all new variants worrying? Because there's a lot of different mutations, for example, that are popping up, and not even within the US, but you see in places like India and elsewhere mutations. And so what makes some of these variants that you're looking at worrying, certain ones, and why is that?
Yeah, so the first answer there is no, not all variants are worrying. Variants are totally a normal part of virus biology. As viruses replicate, they're going to make little errors in their replication, and they're going to become 1 or 2. They'll have small mutations. Most of those either create a virus that doesn't persist, or if it persists, it doesn't really change the nature of that virus. Mm-hmm. But every once in a while, especially when we have billions or trillions and trillions and trillions of these viruses growing in people around the world, by chance, you're going to have a virus create a chance mutation that allows it to grow better and faster and transmit better. And then just based on evolutionary forces alone, it will be able to, if it can transmit more, that means it's more likely to get into another host and then another host. And we say that it outcompetes other viruses that are like it. And so then they end up spreading. And that, of course, is worrying, even if it doesn't change the severity of disease of the virus. It's actually almost worse in some ways to have a virus that can transmit more, because if it keeps the same severity of disease, but it increases the number of people it infects, then of course it creates more deaths and more hospitalizations. So we want to really keep an eye on two pieces. One is it transmitting more? And one is, if it does mutate, is it more destructive to the body? Does it cause more harm? And some of these, and then the other piece is, does it evade our immune system? Which, of course, in the context of vaccines, all eyes are focused on that question in many ways. Are we seeing any variants that are able to sort of what we call escape immunity, get around somebody's immune system that's already been formed? Those are three pieces that we really want to keep an eye on. And if we start to see variants escape immunity, then that, of course, might mean that we have to go back and boost people with a new vaccine that covers that particular variant. And what we don't really want to get into is a world where we have so many different variants and each of them are escaping immunity in slightly different ways, so that we're just trying to play catch up all the time with multiple different vaccines. So one solution is that we create more universal vaccines, a vaccine that maybe can attack multiple or could protect against multiple different lineages of this virus at once. And that might be by finding a conserved region of the virus to vaccinate against, or it might be by including in one vaccine code to create multiple different proteins that would give you protection against multiple strains. So these are top of mind right now for vaccine makers to think about, how do we sort of future-proof ourselves? What we did in the beginning of last year was we took version 1 of this virus, the only version we knew, and all the companies went and started creating a vaccine for it. But because it took a year to develop the vaccine, which was amazingly fast, but nevertheless, it took a year. And so by the time the vaccine started getting rolled out, we were on version 3 and 4 of the virus. And so now we're really having to ensure that those vaccines are continuing to work as effectively in all of these different strains. And some of them we're seeing actually that they don't necessarily work as well for certain variants. And that is of concern. Right now, it doesn't seem hugely destructive. It's not like these variants are able to completely break through people's immune systems. But if we, especially my personal concern is, as the older age classes, elderly people are the very people we've been trying to protect during this virus pandemic, and because they're the most susceptible. Unfortunately, the oldest age classes are also the least equipped to get a new vaccine and really retain immunological memory. So the vaccines generally can wane the quickest in terms of their protection in older individuals. And so what I'm a bit concerned about is that we might get to a place where, say, a year after the oldest individuals in our community, who are generally first in line to get the vaccine, they might have a waning immune response. Mm-hmm. And then we might have a variant that has a little bit greater ability to get around people's immune response. So we might end up seeing more disease again this fall and winter. And so we have to really keep an eye on that and plan for it, whether that's through boosting with new vaccines or continuing to monitor very closely and make sure that the virus doesn't enter into locations, for example, using rapid tests.
When you say some of these variants are more transmissible, like we've had questions coming in, and even like, for example, in the World Newsroom about like, what does it mean that it's more transmissible? Like, does that mean there's more of a risk when outdoors for outdoor transmission? Masks may be less effective, or do you know what do scientists know about what certain variants that are spreading a lot, how they're spreading a lot, and in terms of prevention as well?
Yeah, so the transmission of this virus isn't necessarily the way that it transmits. When we talk about more transmissible viruses and variants, it's not necessarily that the approach that the virus is taking to transmit is changing. It's not doing a better job getting through an N95 or something like that. What it is usually is that the virus levels maybe will stay at their peak titers for longer. Meaning, normally, if you think about how a virus grows, it grows really fast in the body and then it comes down pretty quick because your body has to, your immune system starts tackling it very quickly. If we add an extra day or two to that peak level when it's at, say, 10 billion viral particles per milliliter, like in your nose, normally maybe it will stay there for 1 or 2 days, but if it stays there for 3 or 4 days, then it might it might not sound like much longer amount of time, but it might really increase the likelihood that you come in contact with somebody at that real peak of your infection and transmit it, because you might have an extra 24 or 48 hours to do so. So that's generally, usually we're not seeing massive changes in, for example, a different way that a virus could increase its transmissibility is to create more symptoms in the person. So if you're coughing a lot more, for example, sometimes viruses use that as a mechanism to transmit. We haven't seen big changes in the symptoms that would necessarily suggest that. So we believe that the increased transmissibility is generally that the virus has a greater fitness inside the body, meaning it can stay at high amounts of virus for longer and therefore increase its potential to spread to another human.
There was a question in here that I just came across that the question has to do with whether the variants may impact the testing accuracy and ability, whether it's the antigen or the molecular.
Yeah, so this has been unfortunately the rumor mill has run, and it even went so high as to hit the commissioner of the FDA actually misspoke on NPR recently about this, and said that that rapid antigen tests, like these Abbott types of tests, that they're more likely to be affected by variants. That's actually not true. Any of these tests can potentially succumb to a variant, and what I mean by that is, for example, if you have a molecular test, a PCR type of test, and you get a mutation right where the PCR reagents, the chemicals that we use, the primers, where they're supposed to bind, you can actually lose the signal from PCR. We actually saw that. It's one of the ways that we first saw that the B.1.1.7 variant was actually circulating, was we saw that in a triple target test, meaning it was a test that looked for 3 different parts of the virus, one of those was dropping out, meaning there was no signal, but the other 2 were still there. So we actually saw that that was a variant, and we recognized that. So the point is that any of the tests can potentially lose efficacy if the variant mutates just at the right spot. So far, we haven't seen a lot of examples of it in terms of really any having major impacts. And luckily, the one that we did see the major impact in, which was the Thermo Fisher's TaqPath assay, which is a PCR type of test, it actually had a silver lining in that it allowed us to detect the B.1.1.7 variant. And then that really kicked off a lot of new sequencing efforts to say, hey, we actually have to track this now that we're seeing it's happening quite readily. But in general, the test companies are monitoring very closely. And so far, none of the tests have been particularly susceptible to the new variants. If that occurs, then what is different with the antigen tests is it might be a little bit more difficult for them to build a new test because it's more difficult to create an antigen test up front than it is to just find new PCR primers and create a new PCR test.
Going back to spread, what are you learning about variant spread? It was a very helpful explainer in terms of what it means for a variant to be more transmissible. But in terms of, for example, the health minister in Canada had said, in Ontario, there's been a rise in infections, that it's a lot more younger people or aging more younger are being sick. And to what degree do we know how variants impact the potential for younger people to become more sick? I know that can be tricky to parse out from other exposures, and older people are getting less sick because and less transmissible potentially. So what do we know about that?
Yeah, so that's one of the big concerns with variants. If we start seeing a changing demographic of who's able to get infected. Some of these might be epidemiologically confounded, meaning, as an example, if you're measuring who is getting the most sick in your community, and all of a sudden you say, hey, most of the illness is now happening in the young people. Sometimes that can be through bias, because the old people aren't getting sick anymore because they've been vaccinated. And so you're just starting to focus on who's actually sick. And it's a smaller number of younger people. On the other hand, there is a chance that this virus is going to mutate, or it has already mutated, to actually be able to impact even younger people a little bit more than it was. And there is some evidence building for that. So that's something that we watch. Why exactly it happens isn't quite clear, but nor is, we're still working out and trying to tease out why has this virus been so destructive specifically for the elderly and not for younger people. What I will say is from a research perspective, I think that a silver lining to come from this whole pandemic is we are learning so much more about why viruses impact and differentially impact different groups of people, whether by age or race or sex, and other factors. And so we're absolutely watching that, and it is a serious concern that the variants could potentially start impacting younger people more than they were previously. And if so, then it suggests that we need to really accelerate the vaccines and really the media campaigns to ensure that younger people are able and willing to get vaccinated. Many people have been a bit hesitant to get vaccines.
Here's an unfair question from Brooke. What's the overall risk of getting these variants if you're fully vaccinated?
Well, So I feel like that we haven't done a good job as public health experts to really convey the language that we use to discuss this. There is exposure and getting infected, and then there's actually infection with consequences to the individual. Exposure exposure doesn't matter if you're vaccinated or unvaccinated, just getting exposed is going to be part behavioral if you're wearing masks, things like that. Whether the virus is able to grow in you is one part of the continuum of being infected. And that might actually still happen even amongst vaccinated people. They might be able to harbor some of the virus. It doesn't necessarily mean that they'll then be able to transmit and other things. It could actually be a good thing. Normally, when viruses grow in us and we're already immune and protected, what it does is it boosts our immune system. It gives us a reminder of the virus that we're trying to protect ourselves against. But I think what the question is really referring to is, what's the chance that I will get sick if I've been fully vaccinated? And what we see from that is, depending on the vaccine, some of them are better or worse, but all of the vaccines today have done a tremendously good job at preventing severe disease and death. We've had nearly 100% efficacy to prevent the most severe outcomes of this virus amongst vaccinated people. And that's the most important part. If you're fully vaccinated, it's very, very, very unlikely that you will get a severe disease, even if you get exposed and infected with this virus.
Another question. I'm going to take this question from the world's Twitter feed and then go to a question from Brooke. So this first one then is, are there studies in particular determining if vaccines like the AstraZeneca one can reduce severe disease amongst variants like the one that was first found in South Africa, the B351?
Mm-hmm. Yeah, so that was actually so those studies are ongoing. They're a little bit hard because it's kind of like you're always kind of chasing around. If you're trying to set up a study in one location against one variant, before you know it, a new variant might be there. And so that has proved difficult. It's actually kind of hard now to compare these vaccines where you have one vaccine get trialed in South Africa, another vaccine get trialed in the UK, another in the United States. There's a lot of pieces there that make those studies a little bit difficult to compare, and therefore it's difficult to compare the vaccines against each other. But certainly that's something that we can do post-market, for example. Now that the vaccines are out and about, we can then go and use epidemiological tools to monitor the situation. Say, okay, this is a location where we know that this particular variant was abundant, and this is a similar location where we know that a different variant was abundant. And we can measure the relative efficacy of these vaccines in less controlled ways than the initial trials were. The initial trials are very controlled, meaning they have two different arms, and some people got vaccines, some didn't. But we can use different epidemiological tools in our toolbox to try to tease apart how good the vaccines are working against these different variants. And when possible, we want to do controlled studies as well to really measure it more closely. And that's a major area of science that is ongoing right now in public health to understand just how effective are these different vaccines in different settings.
I guess when we talked about kind of the challenges in public health and in public messaging around this, it's really powerful to hear you say, even following up on that the vaccines are overall, depending on the settings, super effective at preventing severe illness. I'm not sure that you or others could have anticipated that kind of good news. So now we're at this point where people are, okay, like, what is safe for me to do for people around me? And also, it's been a long time, and like lockdown measures can only go so long without all the harm that it's done. So Brooke wants to know, can unvaccinated kids mix safely with vaccinated adults?
It's been a topic of a lot of debate. In general, different places and different people are going to have different tolerances for infections, but kids are at very, very low risk for disease from this virus in general.
And which age range are you referring to when you say that?
Well, really, as soon as you get into anyone that we would consider a kid, the risk is extraordinarily low. Even under 30 years old, the risk of severe disease is very, very, very low with this virus in general. And so when we're talking about kids in grade school, for example, if these children are interacting with adults who've been vaccinated, in general, I'd say that it ends up being a fairly safe way. I would say that it's not completely clear that they won't transmit amongst each other. But even if they transmit to the adults, it's very unlikely that the adults would get sick. And so that's the really important piece there. It's very likely that the kids can still transmit amongst each other if they're not vaccinated. But again, we don't want to lose track of sort of what we talked about at the beginning of the pandemic, which is that so much of everything we were trying to do was to preserve the health of the most vulnerable, the people who are actually getting severe disease. And so this becomes a societal decision. Do we want to do we want to keep the economy and social interactions closed down or greatly limited in order to prevent fairly rare outcomes in kids? Or are we willing to take a little bit more of a risk and allow the economy to open up, maybe because the risk of keeping the economy closed down actually is worse than the risk to a small number of kids getting ill from the virus. So this has been an ongoing discussion this whole pandemic. But to the question at hand, is it safe for kids who are unvaccinated to interact with vaccinated adults? I would say from the vaccinated adult perspective, it is safe at this point. Vaccinated adults appear to be, once you're fully vaccinated, appear to be very, very effectively protected.
If someone is fully vaccinated, should they still get tested prior to visiting elderly family members, for example? This question from Pamela is specifically elderly parents who are fully vaccinated. But I think this also dovetails on some questions we've got about if you've been fully vaccinated, the role of participating in surveillance testing at the workplace as well. So two questions on a similar theme, I think.
Sure. So I think that I don't personally think that testing is going away for this. I think the type of testing and the the rigor that we were doing testing before is going to change. It's going to morph into something more convenient for people, and we're seeing that with these over-the-counter tests. My concern still, while it's contentious and certainly it's a topic of debate right now, can a vaccinated person potentially transmit a virus to a susceptible person, somebody who for some reason hasn't been vaccinated? I would say that there is, from a public policy perspective, I think the direction is suggesting that, okay, vaccinated people should assume that they can't transmit. But I think we have to really keep an eye on it very, very closely, especially as we get further and further down the road, so that people have had a longer duration since they've been vaccinated, say 8, 9, 10 months. We have to really keep an eye to ask the question continuously, is it possible that as a vaccinated person, I could transmit to somebody who is susceptible? And that's an important, there's a lot of people who haven't been vaccinated in this country for lots of different reasons. And some of those very, very good reasons that somebody might not be able to get a vaccine. And so I think that it behooves us as scientists and public health practitioners to continue asking the question, does a vaccinated person have such low risk of transmitting that we don't need to evaluate whether or not they're potentially positive before they go and interact with a vulnerable individual? I have somebody in my house right now who is unvaccinated and won't be vaccinated for quite some time and is susceptible. And so we still test. Even when vaccinated individuals come over, I still ask people to use a rapid test just as an extra layer of protection. It's very simple, it takes 30 seconds, and we get a result 10 minutes later. It's a very simple ask. And I think that we might end up seeing that type of thing happen, especially in places like nursing homes and senior living facilities in the future.
I just want to ask, because this time is really raced by, it's 12:32. Do you have time for a few more questions, or should we wrap up? Sorry to put you on the spot in this.
No, I'm good. I'm good for a few more questions. Yeah.
Cool. This question's from John. Is it possible likely to get long haul COVID symptoms in vaccinated people, although vaccines drastically reduce symptomatic infections? Yes, that's it. That's the question.
I would say it's much, much less likely. It's already fairly rare, not entirely rare, of course. But with vaccines, essentially, it's we're still teasing apart why exactly long haulers, what is the pathophysiology, what's the biology underlying it. But it's very, very unlikely that somebody who's been fully vaccinated will get those kinds of symptoms. I don't want to say that it's absent. In fact, we know that there's breakthrough cases with vaccines. They're not common, but they occur, but it's much, much less likely that you'd have those types of long-lasting symptoms.
That's helpful. Thank you. This is a question from Dino on the World's Twitter feed. England rolled out rapid COVID testing, but it might be scaled down over false positives, according to news reports. How do you see the prospects of that question and false positivity playing into this as a tool?
Yeah, there's really simple solutions. So first, a lot of these tests, the rapid tests, have become there's this like colloquial idea amongst a lot of physicians and folks that the false positive rate of rapid tests are really high. But the reality is many of them have gotten very, very good, on par with PCR. We've done tens of thousands of rapid tests and find almost no false positives. But nevertheless, the concern is that, well, if you're using these at a whole population level and incidence is low, false positives might arise. I think we have to look at it in a couple ways. On the one hand, the best thing about rapid testing is they're rapid. You can confirm rapidly. Have 2 rapid tests, a program that wants to really roll out large-scale testing. If let's say that there's a program that gives a household 20 tests. Give 20 tests and also give 1 additional confirmatory test that's also rapid, so that if you're positive on the first one, which would be a rare occurrence, especially if incidence is low, you just take the second one. And so 10 minutes, maybe you think that it's 10 minutes additional out of your life to confirm that. So unfortunately, though, what we've seen is there's been this hesitation for no good reason. And people have generally said, if you're positive on a rapid test, You have to go and get a PCR test and go out of your way to do that. That's not true. We could rapid test, especially two different companies. In the US, maybe it's Abbott and Quidel, for example. Those are the two rapid tests that we have. You could use both of those if you have, maybe you're using an Abbott test daily, and if you, or every twice a week or something. And if you get a positive, then you immediately revert and you use the Quidel test. And if both of them are positive, it's extraordinarily likely that you're positive. And if they are discordant, then you can make a decision. Either you assume that you're negative and the first one's a false positive. But what you can do, again, because they're rapid and they're abundant and available, just take another one 10 hours later. Maybe you stay home that one day, take another one 10 hours later. If you've been using tests frequently, then the important thing is the virus grows really fast. So 10 hours later, both tests will definitely be positive if you're actually positive. So there's really simple solutions, I would say, to these questions.
And how in reality, how close is the world to these solutions in terms of right now, for example, these tests aren't free. You have to go to a store, limited kind of pharmacies, and that's just in the US. So do you see this as being more and more an actual reality?
I think for much of the world, especially where vaccines are much more limited, much of the world is still grappling in deadly ways with this virus. Even in the US, we still have hundreds and hundreds of deaths daily as a result of this virus. That's a commercial airliner going down every day worth of deaths. And we've been largely vaccinated at this point. We're really getting vaccines out a lot. So a lot of the world doesn't have that. These rapid tests, many of them can be produced for under $1, 50 cents. Governments can produce them and distribute them. And so I do think that, and we actually are seeing that now occur in many countries. They're giving out rapid tests for people to use at home in the privacy of their home and for free, unlike in the US, where we are charging people to participate in public health, which is a real problem in the US. We have still not gotten around to realizing that testing in a pandemic is for public health, not medicine. And we should not be charging anyone, frankly, for using a rapid test, because a test or a PCR test, a test in a pandemic is for your neighbors to help keep other people safe, not yourself. We're really off base in the United States with this issue, but many countries are actually giving them for free. And I think we'll see, and we're seeing companies really scale them up as they've gotten better and better and better over the year. They've honed in their reagents and the chemicals used. And so now they're getting to have very, very high accuracy and be able to be produced at increasingly low costs. And so I think we should anticipate seeing that this continues to grow. And beyond COVID, what COVID has done is it's accelerated these tools and technologies to actually become useful for other things too. For flu in the future, we might end up seeing rapid tests become very important tools as well, for example.
In this moment, though, the US has issued, for example, a global travel warning advising against going to a majority of countries right now amid the variants. And when I think about just day-to-day kind of traveling back and forth within social networks and what we do as humans and what this year has been like, and then even kind of a very globally interconnected world, is that a viable policy to be continuing, of course, amid the variants? And then I'll just have one more wrap-up question for this.
Are you asking about the policy of travel restrictions?
Travel restrictions and moving forward, increasing them amid these variants.
It is, I think there's an argument for and against it, like all things in a pandemic. Certainly, I think, especially if we see that there are variants of concern that are breaking through immunity or that really have a higher risk of causing disease, and we are in the midst of vaccinating our population, and maybe if we can get to a certain level, then even if a new variant comes into the United States, for example, it won't be able to take off because we'll have achieved some level of sufficient herd immunity. Then that would be an argument for holding off, keeping those policies in place for another couple of months. Now, but we have to remember that some of these policies are also quite destructive socially. People live in these countries and have to travel back and forth to see loved ones, for example, or work, and businesses rely on that type of travel. And so it comes at great expense and cost. But that is really what policy, that's what the CDC and policymakers have to really balance and weigh those. They have to take what would happen scientifically from a public health perspective regarding the virus, and then scientifically from a public health perspective regarding economics in the country and in the world. And those are competing interests that are both very, very appropriate to pay attention to. It shouldn't just be focusing on the infections themselves. We have to ensure that we're not over responding to the point where the economic devastation is potentially worse than the devastation from the virus.
Finally, I just want to give kind of wrap things up with final kind of perspectives on the pandemic with the emergence of these variants, with testing, but also with vaccines and with people, at least on the East Coast with summer months. Where do you see this going? I know that it's kind of not a fair question to ask you to look into a magic ball, but based on kind of the realities of what we're learning about this virus, and obviously there's knowns and unknowns, what is your kind of big kind of takeaway in this moment of what's happening and how we should be bracing for the future?
Yeah, well, it's interesting. I'm pretty sure that like this time last year we talked about this exact question, but of course in the absence of vaccines. But interestingly, my answer doesn't change that much. What does change is the magnitude of my answer. Last year, I said that in April we were starting to think about reopening after the first shutdown, and I said we have to really start focusing then on ensuring that we have the pieces in place to ensure that we didn't allow the surges of the fall and winter. Obviously, we did a horrible job actually acting in any sensible way from a public health perspective last year, besides getting vaccines developed. This year, I would say the same thing. But what's different is now this year, what I think is going to happen is we will largely have a reprieve from this virus over the coming months. The summer months will probably see lulls. We're still going to see outbreaks. It's not even getting populations vaccinated doesn't mean outbreaks can't happen. But particularly when you combine it with seasonality and things like that, we will probably see very low numbers. What I'm mostly concerned about is when we get back into the fall and winter again, even with everyone being vaccinated or with most adults being vaccinated, I think we should anticipate continuing to see small surges of cases. And along with those, and they'll generally be seeded by the younger generations in our population. But what I'm concerned about is we might end up seeing that some of the older individuals who have been furthest back from getting vaccines or furthest out from getting their vaccines, as I mentioned earlier, they might end up having a weakened immune response. Their protective levels might not be 95% or 98%. And we might end up seeing those small surges in cases driven by the younger age classes bleed into the older age classes and actually cause some infections and maybe even deaths that are measurable. Where that, I think that it will be limited, but I do think that we have to be honest that that is a real likelihood. And we have to start conditioning the community and the society to understand that that is possible. And we have to make plans today to decide how we want to respond to that. Does that, at what level does it warrant another shutdown versus does it warrant not giving little kids vaccines and taking all of that energy and putting it into boosters for the elderly? Where do we make these decisions? And I think we need to be coming up with a game plan now to ensure that when that does happen, and I do think that we will see smaller outbreaks and surges of cases this fall and winter, just like we did this past fall and winter, but on a much lower level in the US, we need to be prepared for it. We need to have a plan in place. And it's also why I think it makes sense to have testing programs set up and ready to go with these rapid tests. Doesn't mean we have to be using them twice a week between now and then. Mm-hmm. But what we can do is we can have those in place so that if transmission does start to occur, we can just say, we're seeing transmission of this virus in your community, start testing again. And we condition the society to understand how to use these simple tests so that we can keep the reproductive rate of this virus down below 1 and stop the surges from occurring. But if we don't start thinking now, if we just rest on our laurels now, and we assume that we're done with this, it's not coming back this fall and winter, I think we might be kicking ourselves come fall and winter.
And that's regardless of a successful vaccine campaign.
I think it is to a certain extent, regardless. I think that the successful vaccine campaign will mean that everything that might happen this fall and winter is going to be much, much less severe. And maybe our decision as a society is that we're going to deal with it, even if there's a small number of severe cases and deaths in the winter. Maybe we consider it just like flu, for example, in the context of everyone being vaccinated, and we don't make any large changes. But we have to have the conversation now anyway to decide at what level are we comfortable with. And if we're comfortable with 0 deaths and no tolerance, then we have to be prepared to make significant changes. If we're comfortable with a mortality rate of 0.0001%, then maybe we'll be just fine. I think the point is that I want to make is that the virus isn't going away entirely. It's shifting dramatically as a result of the vaccine in our favor. But variants we could have a new variant tomorrow that really does break through immunity. We have to keep in mind that that is a likelihood too. And I think we need to just start looking. We've done a bad job, in my opinion, with the exception of the vaccine, we've done a very poor job of looking 6-8 months out and saying, what do we need to be doing then? And I think we can do that. We have the capacity to do that. We have a lot of resources in this country in particular to do that. And we can at least start creating the playbook now so that we know how we're going to want to respond given different scenarios.
I think that's a good note to end on. Thank you for fielding everybody's questions. And that concludes our discussion, Michael. So thanks again.
Absolutely. Thank you.
And once again, this Q&A has been jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and GBH. You can view the full discussion on the Harvard Chan YouTube channel and on our Facebook pages, and send feedback at Forum HSPH and at PRI The World. Thanks for watching.